Okay. If I could get your attention for a moment, have a little bit of a treat for you. So I want to take a moment to introduce someone to you that actually needs no introduction. He is working on a program that I think each and every one of you will be interested in. You know, he doesn't know it, but I always think of the world in terms of zip codes. In the African American community, we have 2,500 zip codes. And in some of those zip codes, our children really need some help. And this particular gentleman has put together a program that I think could really help some in our community. So the best way to do is just tell you it's Darryl Green from the Washington Redskins. And Darryl, if you come up, he'll tell you about his program.
Thanks, Doc. Dr. Christensen, thank you for having me as well. Such short notice. Thanks for hosting this. This is great. And I'll make sure that someone have my address for next year. You all have met Dr. Bernadine Lacey, my Nana, before. I'm sure you have. Doc, please stand up. Real briefly, and I know you guys are about to move forward, I've been very fortunate to be a professional football player. I played in the NFL for 20 years, and played all 20 years here. And I'm a Pro Football Hall of Famer. I was considered one of the best at my job for a long time. Nobody plays 20 years. That was a very exciting job and afforded me a lot of opportunities, a lot of access, a lot of resources, a lot of influence. I've tried to do the best I could with it. Starting in my own home, I've been married to one woman for 29 faithful years. I have fortunately raised very solid young people. Just had my granddaughter, my son, his wife just brought us two Mondays ago, and you can drop some money in the pot because I've got two daughters that are engaged. So I do wash cars and cut yards on weekends. Well, real briefly, as I mentioned, I've spent my life here in this city, and I guess as a national figure, I founded the Darryl Green Youth Life Foundation, the Darryl Green Learning Centers that operate in the Nashville area, Virginia area, Carolina, and work very hard to make life better for people. But in recent times, I've traveled this country, and I'm getting a lot of conversations with young people. And so I've decided to launch a program that I call the National Myth, MYTH, Busting Tour. What do I mean by that? Folks, there are young people in our nation, many of them look like me. They have an idea that is wrong. They have an idea that their best way out is to be in athletics. Their only way out. Their only way out is potentially to sell drugs. Their only way out is to potentially do rap music. My goal, like with my own son, when he come home and he say, well, Dad, John said today that XYZ, like in about 5 minutes, we'd have a conversation and we realize that John's 1 + 1 is 8 is a lie. 1 + 1 is 2, son. But he can have that conversation because I'm there. So many of our young people are living with their grandmoms and their moms and foster care and so forth, and they don't have information, and they don't believe that they can, if they graduate, it's going to mean something. They don't believe that they can be a successful dad or husband. There's a lot of myths out there, and I've produced, and in the middle of continuing to produce 28 of them, 28 myths, 28 lies. And I'm all over the schools, all over this country, and my goal, I'm going to every school, and we're going to give out these 28 myths, lies that are out there, and these kids are going to say yes, 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 and then we're going to have a conversation, and then we're going to have a Q&A, and then we're going to give out the questions again. The same thing I did with my son. In less than an hour, we're going to have young people that believe something that's a lie, believe something that is the truth, and give themselves a chance to be successful. It's not a program. I know we love programs. I've got a program. It's a conversation. It's a conversation. It's a dialogue. It's a moment, as we have done with our own kids, when either rap music, ESPN, Kenny down the street, the television, something other than sound wisdom has presented in their ears about life, about a situation, about their potential for future success. And all I want to do is go and have a conversation. And in closing, I had a conversation with a kid, 17 years old. He spent 13 years of his 17 years in foster care. And he said he's a linebacker. And he said how many guys he hit and broke their helmets, he broke some legs, he's done a lot of things. And he said, Mr. Green, he said, you know, I love doing linebacker, so instead of going out there and hurting somebody or robbing someone, there's a certain amount of anger that he has, and I can understand that. Foster care for 13 years. And in 5 minutes, we had a conversation just like I'm talking about. And I said, you know, had you ever thought about, what if you forgave your parents? What if you said, you know what, I forgive them. I don't know what my dad was going through or my mom. I don't know what his mom and dad. But if I just say, you know what, I'm just going to forgive them. I said, you probably become a lot better linebacker. I said, you know, even look at, you know, when I look at your face, I see such a great young man, but there's something on your face that just, the smile is just can't release. And I prayed for the kid. I prayed that God would cause his countenance to be released. And I got an email the next day. It said, Mr. Green, you know, I never heard anybody talk to me like that. And he said, I'm going to forgive my parents. I'm going to forgive them. And I haven't spoke a lot to him in the last 3 weeks. But I believe that grown, mature men that have a life that they can present to these young people in a history in 5 or 10 minute conversations. I did it with my own children. You know, my son never slept with a girl until he was married. And you know, my dad never knew his dad, and my dad was an alcoholic. They got divorced. I had a child out of wedlock until I got my life right. And here's a kid, 4 generations from that man that we never knew. Solid moral human. And his wife and his daughter they just had. I believe this. I'm just stupid enough to believe that without a program, through sound conversation, as I've done for years, in their bedrooms, in the living room, in the dining room, just sitting down, talking to my kids, and making sure that Johnny or Pookie or the internet or the rap song or the athlete or whoever it may be does not lead them down some foolish road. So it's the National Myth Busting Tour. I like to come to your school and to your city, in your town, your inner city schools, or wherever they may be, and myth bust. Thank y'all so much for the time.
So we're going to make sure that we get connected with Daryl's program and we get some myth busting going on because I'm sure, as Brian Smedley knows, social determinants of health are profoundly important, and myth busting is part of the job. So thank you so much for taking the time.
It's a tough act to follow, but I will do my best. Now it's time for the luncheon presentation. We'll open the lunch program with a presentation entitled A Campaign for Advancing Health Equity, Establishing a National Health Equity Leadership and Exchange Network. This presentation will introduce the audience to a special initiative to increase coordination around a collaborative, cohesive, and sustainable campaign specifically focused on health equity laws and policies across the United States. At this time, I will call our panelists, our presenters to the stage. This presentation will be delivered by Daniel Dawes, Executive Director of Government Relations, Health Policy, and External Affairs at the Morehouse School of Medicine, Dr. Brian Smedley, Vice President and Director of the Health Policy Institute at the Joint Center for Political and Economic Studies, and Dr. Garth Graham, President at Aetna Foundation. Our first presenter will be Dr. Graham.
Thank you, sir. Good afternoon, folks. It's good to see a lot of old friends and a lot of old colleagues who have been a part of this fight and I'll say struggle in terms of how we improve health disparities across our country. My part of this presentation is going to be relatively short, and I'm going to give you the conclusion in case you fall asleep while I'm talking, which has been known to happen even here. And to tell you that not long ago after I became president of the foundation, Daniel and a group came to talk to me about what do I think would be some of the transformative things that we could fund that would genuinely make a difference. And you know, we've been debating this idea and going back and forth for a while, and I think we're happy today to announce this programmatic activity that Daniel and Brian have put together and that we're supporting, that I truly believe is going to make, has the potential and is going to make great change across this country. But I'm not going to steal their thunder. I'm going to give you some background in terms of why we're even involved and why I cared about this to begin with. So let me start off with a couple of slides, and those of you who know me know this is something I talk about a lot, which is that as a country, we live in totally different countries. Almost totally different countries, depending on where you live. So that's a slide, but suffice to say that if you look over there in South Carolina or Montana, people there have life expectancies that are about the life expectancy in Afghanistan or about the life expectancy that you see in places like Iraq. If you even go into a place like New Orleans and you look at just going from one ward or one area to the next, you see where there are individuals there, in particular minority communities, who live an average of 55 years in their life. Well, that's about how long people live in Gambia, in Angola, in some of the places where they're in genuine civil war. And so when I teach my medical students, I say we don't need to go and get on a plane and go to Africa to see some real problems. Just go across the street. Or just, you don't even need to take a bus sometimes. Just walk a block further than where you normally try to walk to avoid seeing some of the challenges that we really face. And when you look at just how different lives people live in our country, I think it is truly amazing. In fact, some of the only places that have a lower life expectancy than those places that I was talking to you about in New Orleans and in other places are only about 3 other countries, like Sierra Leone, and some of these really places where there's true devastation. So there's devastation occurring right here locally. So even if you just want to take the red line, right, and go from one part of DC to the next, you see where people can go from 7 years difference in life expectancy. 7 years. That's a totally different world, right? So we have people living who we walk by in terms of side by side, who live, who have a totally different life expectancy and potential ability to endure their lives compared to others. And all of these are predominantly minority communities. So we're talking about our communities in terms of the world that we're facing. So when Daniel came and talked to me and we're talking, they had done a lot of work. I had done a lot of work when I was in the federal government around the Affordable Care Act. And I think we all had thought that certainly once the Affordable Care Act was done, disparities would be eliminated and not much work would be left to be done. And so it's kind of interesting how things have been evolving and why there is now an utmost need for leadership around these issues. So this is just an example showing you in terms of states that are expanding Medicaid. It looks red and blue, it's just political lines in terms of which states have decided versus not. But then if you look at the history of our country in terms of doing things like this, we've been here before. In 1966, only 6 states originally participated in Medicaid. And it took really almost 20 years later when Arizona joined in 1982 for Medicaid to be truly national. So what does that mean? It means that when you start these efforts, it is just the start. These are going to be ongoing activities that'll take 10, 15, I'm talking about almost 20 years later from when Lyndon Johnson started Medicaid to when it was truly national. And so if we look at the trajectory around the Affordable Care Act, and if we really, really want to make impact, we have to think about how do we create a leadership network and be able to genuinely achieve those outcomes. So suffice to say that when it was brought to us this idea of funding and supporting a health disparities leadership network across the country, after really taking a look at history, taking a look at the statistics in terms of where we are, we decided that this was something that was important for us to get behind. It not only included this concept of creating leadership across the country, engage the REACH Coalition that has a track record of success in a bunch of different areas. So I won't steal Daniel and Brian's thunder in terms of talking more about the program, but suffice to say, if I could leave you with a couple of messages, I would say this. One, remember the country that we live in and understand a little bit about the true dynamics and where the real need is. And there are pockets of need here that are so desperate that we all need to be acting right now. And it need not always be legislators and policymakers. It can be folks from all different walks of life. And I think that's what I tried to show in terms of those statistics. Second thing I would like for you to remember, if you fell asleep as I was going through all of this, is that this is going to be an evolving process. And all of these things, as they started back with Medicaid and all these things that were done in the 60s and how it evolved over time, are going to change. And how we influence those change, the components of that change, is going to be reflected in terms of the leadership that we have, as well as the proactive nature that we take in terms of moving forward. So I'm going to stop there and turn things over to Brian. But suffice to say that this is just one component of the kinds of things that we would like to see moving forward in terms of creating true leadership around health equity. Brian?
Thank you very much, Garth. And I want to start by just thanking Dr. Graham for both his leadership when he was director of the Office of Minority Health here in Washington, but also his leadership at the Aetna Foundation, making this very important grant to help us get started with this Health Equity Leadership Exchange Network, which Daniel will talk more about shortly. But I hope this is something that you all will see a great need for us to share information and begin to put in place the solutions that we know exist. We know that there are strategies, often community-based strategies, that can advance the ball on health equity. The question is public will and accountability. And we believe that this network is going to help achieve both of those aims by ensuring that all of us have a seat at the table so that we're sharing what we're learning in the various communities that we work in, and more importantly, that we find ways to hold folk accountable as many new important policy reforms are put into place. Again, my role here is like Dr. Graham's role, just to set the stage for why we need this Health Equity Leadership Exchange Network, and then to talk with you all about how we put this into place and hopefully get your support in this process. So let me just dive in to my slides, if we can pull those up. Essentially, as Dr. Graham said, all of you know that the Affordable Care Act is necessary but not sufficient in and of itself to address the challenges that we face. We know that people of color across the life cycle, from the start of life at birth, have poor birth outcomes, higher rates of infant mortality, lower birth rate, all the way through childhood and adolescence with the array of chronic and infectious diseases and violence that affects our community. And then all the way through adulthood with the higher burden of disease and disability and shortened lifespans at the end of the life cycle. This is a heavy burden of disease and disability that has a tremendous human cost, but as I'll also talk about, has an important economic cost for the nation. We know that these racial and ethnic health inequities persist even when we control for socioeconomic differences. So one of the most important and most depressing statistics to me when you look at infant mortality, the fact that African American women with a college degree will experience higher rates of infant mortality than white women with less than a high school degree shows you that education is critically important, but race remains an important predictor of our health status as well, for reasons that we will get into. These are data from the most recent National Healthcare Disparities Report that the Agency for Healthcare Research and Quality puts out. A very important report. This is the 10th such annual report. And what this report shows is that we've made little progress in the 10 years where we've been measuring the quality of care and access to care for populations of color. As you can see from this slide, many communities of color are not seeing improvements relative to white Americans or other reference groups, more economically advantaged groups, when it comes to the quality of the health care that we receive. And in fact, on many of these measures, the gap remains very stagnant. We know that there are important healthcare quality gaps. African Americans have higher rates of admission for lower extremity amputations than whites. Asian Americans are less likely than whites to get care for an illness or injury as soon as wanted. American Indian and Alaska Native women are twice as likely as whites to lack prenatal care, and so forth. And Latino children and their parents are more likely to experience difficulties communicating with their provider. I mentioned that there is a tremendous human toll, which everybody in this room, I'm sure, finds to be morally unacceptable. But there's also an economic case, as we've talked about in past brain trusts here, that there are economic costs associated with that higher burden of disease and disability, the higher medical costs that we pay because of that higher burden of disease and disability, in addition to indirect costs associated with these health inequalities. The fact that when people are sick, our businesses lose productivity, people lose wages. And when people die prematurely, not only do families lose that breadwinner, but we lose revenue at local, state, and federal levels. This cost is very significant. In the study that we released in 2009, we found that over 30% of direct medical costs for African Americans, Latinos, and Asian Americans were excess costs due to that higher burden of disease and disability in the population. If we'd eliminated those health gaps, we would have saved about $230 billion in the 4 years between 2003 and 2006. And if we add in those indirect costs, the total bill to the nation is $1.24 trillion, which we believe is a conservative estimate of that economic burden. Like Daniel, we also analyze the Affordable Care Act. Daniel has a very extensive analysis that looks at the many dozens of provisions within the law that are specifically focused on advancing equity, for which we have Congresswoman Donna Christensen to thank for pushing those provisions through when the law was debated in 2010. But you can also find this analysis on our website. And we've discussed this at great length here today and elsewhere. We know about the insurance coverage expansions. Critically important that all states eventually accept the Medicaid expansion, because many, many millions of people will fall into that coverage gap. And insurance, of course, is a community issue, not just an issue for individuals and their families. It matters to all of us that we all are covered, because we ultimately pay a higher premium when folks are not covered. We know that the various subsidies and premiums will help to stimulate the insurance take-up, particularly for small businesses, for example, where people of color disproportionately work. We also know that having an insurance card in and of itself is not enough in many communities, particularly communities of color, where we often find a lack of geographic access to providers, primary care providers, oral health care, behavioral health care. These providers are not in these communities simply because health care is a market commodity, and providers are going to work where they can make a living. And in many of our highly segregated communities with high levels of poverty concentration, it's very difficult to find a provider. So we need to ensure that we better align our healthcare resources to match community need. And so several provisions of the ACA do just that by expanding funding for community health centers, by reauthorizing the very important health professions programs that incentivize providers to work in underserved communities, and providing funds for school-based health centers and other places to better put those healthcare resources where people can access them. Other important provisions include data collection and reporting. This is critically important, but often overlooked when we think about the ACA and what it will do to advance equity. So the data collection provisions require all federal grantees for the first time to collect consistent race, ethnicity, and primary language data, which will be important to help us monitor when and where we see barriers in terms of access to care as well as quality of care. And again, that's very important for accountability. Other important provisions provide resources for cultural competence, education, and training, the workforce provisions that I mentioned earlier, and perhaps most importantly, in my view, is the Prevention and Public Health Fund, because we know that for every dollar that we spend from federal health dollars, only about 5 cents is spent on prevention, and we need to better balance that ratio by investing more in prevention so that people can be healthy in the first place. So more must be done, and clearly, as Dr. Graham's slides alluded to, particularly working upstream to address those social and economic and environmental conditions that shape health are critically important. I'd note that the map that Garth showed, showing differences in life expectancy in New Orleans, very important to show at a local level the geographic distribution of health. That map actually comes from research that we at the Joint Center did with our Place Matters team in New Orleans, in Orleans Parish, where the team decided to look at which communities are healthy and which are least healthy, finding that 25-year difference where in the central city in New Orleans you can live to be about 55. That ought to be unacceptable in a country with this wealth and abundance. So we need to do more to address those upstream root determinants, the heavy concentration of health risks in communities of color, but we need to do more. You all know that there's an unfinished agenda, and Daniel will talk specifically about the HELEN, the Health Equity Leadership Exchange Network, will help us to address this. But we know that there are many millions of people who will not gain coverage as a result of the ACA and the way it's being implemented now, particularly legal immigrants who remain ineligible, for example, for Medicaid. We must ensure that the health workforce reflects the diversity of the population. With the growing diversity of the U.S. population, it's clear that our healthcare systems, unless they address diversity of the healthcare workforce, are going to be poorly prepared to deal with and address the needs of the population. We must align our healthcare resources where they're needed, as I mentioned earlier, ensuring that we get primary care providers and specialty services into medically underserved communities and health profession shortage areas. And we have to address concentrated poverty and the heavy concentration of health risks in communities of color through Place Matters, the Joint Centers initiative, where we build the capacity of leaders and communities to address these very conditions. We're looking at how to expand place-based investments, addressing food justice, environmental justice, but also helping to ensure that as we make those improvements in communities, that people can have the housing choices to stay in their community if they so choose, because in many cases, when we make these investments in places, we are inadvertently causing gentrification and the displacement of people who've been in these communities for many years. So as I hope you can tell, we need comprehensive strategies, and we know what works. Now our challenge is to share that information and build the public will so that we can finally address health equity square on. Thank you very much for your time and attention, and I'm now going to turn to Daniel Dawes to talk about the Health Equity Leadership Exchange Network.
Good afternoon, everyone. Congresswoman Christensen, I want to thank you so much for the opportunity to unveil this new initiative, and it is in her honor that we are unveiling this after almost 20 years of service in Congress and really being that torchbearer for health equity, making sure that it's prioritized in policy and both through legislation, regulations, and in various programs across the United States. We are very, very delighted to, of course, unveil this in your honor. And I do want to recognize my colleagues, Dr. Graham and Dr. Smedley, when we first got together and we talked about what this should look like, what is exactly needed. You know, Garth really asked some tough questions. Brian and I were trying to go back and forth and figure out how to flesh this out so it's, you know, it's workable, that we don't get too ambitious, as we're moving forward. And I do want to thank Dr. Graham for his tireless advocacy and his leadership. You know, while Congressman Christensen was in Congress here pushing forward, he was there at HHS making sure that this issue of health equity was prioritized. So kudos to both of our champions. And I want to just begin by talking about the problem. So Dr. Graham and Dr. Smedley talked about the challenges that we see in healthcare in terms of healthcare disparities and disparities in health status. And we, for those of you who keep up with the news, you know that there was a recent Supreme Court decision on affirmative action. Justice Sotomayor basically gave a courageous dissent, stating that we shouldn't wish away rather than confront the racial inequality that exists in our society. The way to stop discrimination on the basis of race is to speak openly and candidly on the subject of race. And the Attorney General, Eric Holder, praising the justice, said that this great country still has a ways to go before our founding promise of equal justice and equal opportunity is fully realized. And I think this squares very closely with what Congresswoman Christensen has always said, that health equity really is the civil rights issue of the 21st century. And it's something that we all believe and hold dear to our hearts. And it should come as no surprise then that oftentimes health disparities result from failing to develop, review, analyze, and implement laws, policies, and programs that utilize a health equity lens. In fact, policy is a driving force for many of the health inequities that we've observed. Laws and policies have been developed without regard to the impact they would have on minorities and other marginalized groups. We know that laws and policies have been implemented without considering the impact to health equity. So why the urgency? Because health law and policy is an evolving area and will have serious implications for many populations over the next several decades. We know recently several landmark pieces of federal legislation were passed by Congress that were designed to have a positive impact on the health of underserved populations. And of course, the extent to which health policies are implemented or even implemented well remains questionable and sometimes disconcerting to us. And we'll talk about that as well. So why the urgency to act? You know, there's a disconnect. We've realized that there was a disconnect between the advocacy that was involved during the development and passage of policy and the advocacy that has been involved during the implementation of that respective policy. And so we want to re-engage folks across the United States, engage them, get them excited to pay more attention to this implementation phase as we move forward. As you can imagine, it has been quite difficult for us to coordinate a cohesive and sustainable campaign around health equity. Little has been done to comprehensively, transdisciplinarily, and collaboratively coordinate health equity leadership, to exchange timely and essential information, and to also generate or actualize health equity strategies and approaches at the local, state, regional, and federal levels. So let me go back 30 years. To talk about the progress. We've made tremendous progress over the last 30 years. You might recall, for those of you who were around in 1983, that the Secretary of HHS at that time, Margaret Heckler, recognized that while the overall health of the nation had been improving, the overall health of racial and ethnic minorities were terrible. And so she set about establishing this task force around African American and minority health. They came out with a landmark report, as many of you remember, and that report helped to establish the Office of Minority Health. That was in 1986. And then for the very first time in 1990, nobody had ever prioritized reducing health disparities in our Healthy People agenda. This is the nation's public health agenda. And for the first time in 1990, we were able to prioritize the reduction of health disparities. Continuing on, there were some investments throughout the 90s, looking to collect data around this, to conduct more research. And folks were instrumental in coming up with the evidence base for why we needed to continue to push this issue. In 2000, Healthy People 2010 came out, and they went beyond reducing disparities to saying, we're going to eliminate health disparities over the next 10 years. Very, very bold at the time. And then that, of course, in the 2020 report, they're now going beyond eliminating health disparities to saying we can achieve health equity over the next 10 years, and we can improve the health of all communities. if we really care about this issue. So fast forward, of course, we passed the landmark health reform law. Many individuals seem to have this notion that it is the end all, it will address all of the disparities in the system. That certainly isn't the case. It is the first ever, most comprehensive law directly addressing health disparities, but there's still so much more left to do. And we need to make sure that as that law is implemented, it is implemented appropriately, that it has a positive impact on the communities that we care about. So let's talk about, despite all the gains that we've made though, let's talk about some of the concerns that we have, some of the trends that we're seeing. You know, many of the ACA's health equity provisions, the mandatory funding provisions are expiring. They're slated to end either in fiscal year 14 or 15. We're very concerned about that. When you look at the impact of sequestration on health equity programs, yes, we have somewhat of a delay for the next 2 years, but the first 2 years of sequestration had such a negative impact on many discretionary health equity programs, it raised a lot of concerns for us. And we know that as the years continue, it will have a more serious impact on these programs. Then, deficit reduction proposals. You've heard me say this before. I am extremely concerned about the proposals that are out there. We know after the elections this is going to come back and folks are going to be looking seriously at these issues. We want to make sure that folks understand the implications of these on health equity. And then, of course, the relegation of health equity during the implementation of various health policies and laws causes us some concern. But let's look over at the federal health disparities bills. You know, I think that we're also, it's interesting, we're very concerned about the decline in bills that have been introduced tackling health disparities. You'll notice that when the Congresswoman came into office in 1997, in the 105th Congress, there was a sharp increase in the number of bills looking at this issue of health disparities. I don't think that's a coincidence. But then after the health reform law now, I guess folks are extremely concerned about making sure that ACA is implemented and implemented well, that we haven't seen that chart increasing. And that causes me some concern because now we're going back to levels seen in the 108th Congress or 109th Congress. And that's the same thing that we're also noticing with minority health bills. Same trend there as well. And then, of course, as we move forward, we're also concerned about the retirement of key health equity champions in Congress. And of course, very, very concerned about Congresswoman Christensen leaving us. I don't know if we can change your mind, but we understand. But we really are concerned about our champions, making sure that we have champions in Congress as we move forward. So with all of these concerns, we believed it was the right time to launch a national campaign for advancing health equity. And our objective is to establish this national Helen to bolster health equity leadership. We want to get folks exchanging ideas and strategies, sharing information in as close to real time as possible with thoughtful analysis on how these laws and policies might impact our communities. This is a collaborative effort, and I want to, of course, thank and recognize our colleagues on this. The National Reach Coalition with Kathy Morales has been instrumental, Morehouse School of Medicine, the Aetna Foundation, the Joint Center for Political and Economic Studies. Together we will run this and lead this initiative. And of course, working with many of you here in the audience, we've had the opportunity to speak, looking forward to collaborating in that respect. So what are we going to do? We're going to recruit at least 100 national groups and organizations to participate in the project. We want to make sure we have organizations, coalitions, groups that are very, very passionate about this issue, are serious about advancing a health equity agenda. We're going to provide a forum for health equity champions to share information about timely, relevant, and pressing policy issues impacting health equity. We're going to actively inform and monitor the development, the implementation, promotion, and impact of local, state, and national health laws and policies on racial and ethnic health equity. Then we're also going to provide a mechanism to research, analyze, summarize, and disseminate information for education and bidirectional exchange of information to engage people in a broader dialogue. And then, of course, we're going to make sure that the messages that we're sending out are culturally tailored, that folks don't necessarily have to have a PhD or an MD or a JD to understand health policy, but that it's understandable to the folks at the local level. Some specific activities that we're going to be involved in: we're going to create a federal and state health policy analyses, create many of these fact sheets, issue briefs, utilizing a health equity lens. We want champions to understand where the challenges in advancing health equity lie. And we have seen that when a law is passed, and there might be certain committees, internal committees at the administrative level, and yes, when they are pushing for the health equity agenda internally, sometimes things get lost. We've noticed that in proposed rules. There might have been the inclusion of some health equity priorities, but then when public comments are received and the arguments are made against that overwhelmingly, then by the time they come out in interim or final rules, those health equity provisions are gone. And so we see a watering down there. We're also going to develop a 50-state and U.S. territory survey, fact sheets, tracking charts, matrices, and briefs on select issue areas discussing the economic impact as well as the legal and policy implications. We understand, as I live in a southern state, that you can no longer make that moral argument. We have to arm champions with the information to show the economic impact and the legal and policy implications. And then, of course, we're going to develop fact sheets on ACA-specific programs and initiatives, such as the health equity provisions, as Dr. Smedley mentioned, the delivery system reforms that are coming out. How are they going to ensure that we are increasing health equity and we're not causing some risk adjustment in the system? Same thing with PCORI, and then, of course, grants and others. And then we're also going to have access to a library. We're going to develop this library where Helen participants are able to access information analyzing federal and state policies, feature proposed and existing health equity legislation, regulations, statutes, executive orders, any bulletins, FAQs, any sub-regulations as well. We're also going to have innovative health disparities research. We know that many of you have been involved in health disparities research at your respective academic centers. Well, there's so many great things happening around the country, but yet there's not this one-stop shop where folks can access that. Perhaps there's something that is going on in Michigan that we might be able to employ in Tennessee or another state, and vice versa. And then, of course, we will feature different health policy tools, articles, and other informative resources. And then, lastly, we are going to allow an access to an online forum of an interactive map of the United States. And this is where folks will be able to provide access information on health equity champions that are in the area in each of the 50 states and the U.S. territories. We're also going to make sure to highlight the laws and the policies and programs in those states that have an impact on health equity, whether it is favorable or unfavorable. The economic impact of health disparities in each state. We understand the need to provide those figures for folks. And then, of course, member surveys on key health equity policy issues. And if you are interested in signing up, you can visit the reachcoalition.org/Helen. You could also send an email with your information. They will be happy to contact you. And then you can also call and give in your information. So looking forward to working with you all on this initiative. Thanks so much.
Thank you so much. You weren't here early this morning, but our keynote talked about the fact that 2019 we will have been here for 400 years, and that's 400 years of waiting. And so I think this initiative that you're starting is right on target to help us move from where we are to where we need to be. So thank you very much. One or two questions, if there are any. But we want to really thank them for the three great people. Daniel was one of our fellows as well, by the way. But Daniel Dawes, Attorney Daniel Dawes, Dr. Brian Smedley, and Dr. Garth Graham for that great presentation. And it's really inspiring. It should be very encouraging and energizing to us to see these well-respected health equity champions themselves leveraging resources and expertise to really make a difference. We'll take this one. We got two questions. That's it.
Bob Griss,
can you make them brief?
With the Institute of Social Medicine and Community Health. This sounds like a very strategic project, and I'm very glad to see it evolve. I'd like to ask how you think this can be useful for identifying the impact of social determinants of health on the total population. When you talk about health equity lenses, you're frequently focusing on the differential between minorities and the majority population. But as we have seen, it's the majority population is also adversely affected by the social determinants of health. Even the states that are not expanding the Medicaid program, they have the poorest health. Their populations, minority and majority, would gain the most from a stronger, accountable healthcare delivery system. How can this project that you're talking about invite the majority population to also see the benefits to them of eliminating the disparities through a more accountable system?
Thank you.
So, I'll start off and then turn it over to my colleagues who know more than I do. And I'll say that, I think the health disparities and health equity definitions differ. And I think they differ because health equity is about what you're talking about, sir. That everyone, regardless of either social, race, ethnicity, et cetera, have equal access, and that's the equity portion. And so I think a lot of what you heard Daniel talk about is this focus on equity. I think disparities is a deficit, equity is the equalizer. And that's kind of how I would think about it. And I think in general, what we're talking about in either this or even all the other things that we do, and a lot of the stuff that has been championed by Donna Christensen in particular and some others, is a lot about equity as opposed to highlighting the deficit around disparities.
That's right.
Let's take the next question.
Thank you, Congresswoman Christensen, and to the panelists, in particular to Attorney Dawes, Neva Lubin-Johnson from Chicago, general internist. Glad to see the progression of bringing out these issues in terms of achieving health equity, going to another level. Particularly want to know how you expect to get this information out to the masses. I'm from Chicago, and when I had the opportunity to talk about ACA and getting information from you, Attorney Dawes, about what was going on in terms of taking out a lot of the issues related to achieving health equities in the ACA. I mean, people just didn't know. Right. It was like I was speaking a new language to them. They were totally unaware that things had been passed in the bill that were being gutted. And I would hope that whatever happens with first e-newsletter or whatever announcement, that there is a continuous dialogue and outreach to the masses of people, to legislators, be they federal, state, local, about what's been in the bill, but what has been taken out.
Absolutely. We totally agree with you, and we're going to make a concerted effort to make sure that we're getting the folks that might not necessarily have the resources to conduct this sort of analysis, to empower them, but we do want to also go after the thought leaders as well and bring them in so they can also reach their respective members. So yes, great point. I appreciate it. Thank you.
Let's thank them again, and remember, I don't know if we can get that slide back up with the information on how to reach you. If we can put it back up. But there was an open invitation, as I heard it, yes, to participate. So please do. Thank you. Give them a round of applause. Oh, and she wants a picture. Oh. Okay, just it's a very special part of our program, and there are some folks that have joined us, and we want to acknowledge some very special individuals and applaud them with the 2014 CBC Spring Health Braintrust Awards. Dr. Puckrin, are you here to join me on stage? And who's handling the awards for me? Oh, there. Okay. Okay. Our first awardee is someone that I'm pleased to call a friend and colleague. Her bio is in your folders, but, and that's Congresswoman Maxine Waters. Unfortunately, she has like 2 hearings that are keeping her on the Hill, so she's not here. We're going to show a brief thank you from her later. But whenever any legislative proposal that addresses a health equity, but HIV and AIDS and the Minority AIDS Initiative and Alzheimer's especially, Maxine is there. She's not only established an impressive legacy in these spaces, but she's earned the deference that I and so many of my colleagues, not only in the Congressional Black Caucus, but Congressional Tri-Caucus and the Congressional Progressive Caucus rely on her for. Without her, so many strides in health equity that we've made through legislation would not be real. Without her awareness about the effects of Alzheimer's and the practical solutions for families who love those with that devastating disease would be less. Without her, the Minority AIDS Initiative would not exist. And without her and Congressman Lou Stokes, I would not be standing here today as the chair of the Health Brain Trust. So I'm really grateful to her and so pleased to recognize Congresswoman Maxine Waters. And is the tape ready? Yes. We can run the tape.
I am so honored to receive the 2014 CBC Spring Health Brain Trust Congressional Leadership Award. And I'm sorry I cannot join you in person to accept it. Please allow me to extend my profound gratitude to the Congressional Black Caucus Foundation for this great honor, and allow me to especially thank my friend and colleague Donna Christensen for all of her work over the past 15 years as the chair of the CBC Health Brain Trust. Congresswoman Christensen has been the chair of the CBC Health Brain Trust continuously since 1999. In fact, when I was the chair of the CBC in 1998, I chose her to succeed Congressman Louis Stokes, who created the Health Brain Trust and who was retiring that year. I chose her because I knew that as a doctor, she cared deeply about health care, equity, and minority health issues. In the fall of 1998, Louis Stokes, Donna Christensen, and I met with Donna Shalala, the then Secretary of Health and Human Services, to discuss the alarming rate of HIV infection among African Americans. The result was the rollout of the Minority AIDS Initiative, a program to provide grants for HIV/AIDS awareness, prevention, and treatment in African American, Latino, and other minority communities. Since then, Congresswoman Christensen has worked with me to expand funding for the Minority AIDS Initiative. Because of our efforts, the initiative received more than $425 million in fiscal year 2014. Indeed, it was one of the few programs that actually received an increase this year, despite the prevailing environment of fiscal austerity. I have been successful in addressing many health issues, such as AIDS, diabetes, Alzheimer's, and cancer, because of the strong support from Congresswoman Christensen. Congresswoman Christensen has worked tirelessly to bring attention to the alarming health disparities affecting African Americans and championed legislation to eliminate these appalling disparities. In 2009, she introduced the Health Equity and Accountability Act, a comprehensive bill to improve minority health, which was drafted with the input from the CBC, the Congressional Hispanic Caucus, and the Congressional Asian Pacific American Caucus. Congresswoman Christensen's tenure as chair of the CBC Health Brain Trust has been truly groundbreaking. For me to receive the Health Brain Trust Congressional Leadership Award during her final year in Congress is a special honor that I will cherish always. So I thank the CBCF for this award, and I join with the CBCF in thanking the Honorable Donna Christensen for her years of service and her dedication to ensuring health equity for all Americans. Thank you so very much.
Our next honoree, a young woman who's one of the best kept secrets and health equity warrior secrets among us, is someone who I'm pleased to applaud with the 2014 Spring Congressional Health Braintrust Congressional Staff Leadership Award. Her name is Amy Hall, and would you join us on the podium? Some in this room may not recognize her by face or name, but her efforts behind the scenes have directly and indirectly touched the lives and improved health care, health and wellness, and thus life opportunities of millions of Americans. You see, as a member of Congress, I can tell you that so often the best staff members, those who get the most work done, are too busy getting that work done to worry about being recognized, and Amy is one such person. But she's much more than a humble and brilliant woman, really, and I honestly don't say this because she spent some of her summer childhood in the Virgin Islands, but I know this because for the last several years, whenever we needed any help, whenever we needed an immediate answer or some guidance, she was always the first person we called on, and she was always ready to assist. And if there was something that couldn't be done, she'd help us find a way around it or a plan B. So we really are very pleased to be able to recognize her with the Congressional Staff Leadership Award.
I just wanted to say a few words of thanks, and I want to start by thanking Congresswoman Christensen and echo one of the previous speakers who said, can't we convince you just to stay a little longer? And thank you to the CBC members and staff for recognizing me today, and in particular Britt, who I have worked with for years and is wonderful and talented and funny, and it has always been a pleasure to work with. When I was told about receiving this award, I started thinking about what I would say in a minute or two to express my gratitude, my honor, my pride at being recognized. And that got me to thinking about all the issues that I've worked with over the years with the CBC, the Patient's Bill of Rights, the Children's Health Insurance Program, ensuring access to drugs and treatment under Medicare, coverage of breast cancer treatment for low-income women in Medicaid, health disparities, hospital issues, drug issues, the Affordable Care Act. And I realized I couldn't possibly run through all of the issues and all of the ways that the CBC, its members and staff have been instrumental in fighting to eradicate health disparities. And as we just heard, we have a really long way to go. And the presentation was actually inspiring because I'll admit it, there are days when I get up and think, oh man, I can't do this anymore. It's just so hard. You feel like you're swimming upstream. But it's presentations like that and awards like this and people like Britt and Congresswoman Christensen that make it all worthwhile. And anyone who knows me knows I don't get up in the morning to get recognized. I get up in the morning to make sure that the issues and the injustices and the people that really matter are helped. So thank you.
Thank you. Thanks. And Britt has put it in the box for you.
Great, thank you.
The next award is really a special award that I want to give. And, you know, when you come to Congress as a delegate from a territory that at least half of the members of Congress have no idea where it is. I've had members tell me that they were in my district and they just got back from Jamaica, okay? Or ask about ambassadors from my district and all of that kind of stuff. So, you know, and yes. And because we're delegates and we don't have a vote on final passage, and in Republican majority years, not even in the committee of the whole, we don't raise a lot of money. It's very difficult for us to raise money. But you know that to be reelected, you need to raise funds. It's, you know, you have to raise money. So I want to give this person an award because she's been with me throughout these 18 years, and she took it upon herself to be a fundraiser for a delegate without a vote who came from a place that most people didn't know where they were from and where she was from, and that's Hannah Hunt. And Hannah, would you join me on the podium? So You know, we honor staff because you don't see the staff that's behind the work, and I'm honoring her because you don't see the work that she did to make sure that I was here to work with you and for you for these 18 years. So Hannah's been on the Hill for quite a few years. She worked for Bill Layman. Was he from Florida, you said? Yeah. From Florida, one of the past cardinals in the House, chair of Appropriations, the Appropriations Subcommittee on Transportation. And she's been doing fundraising for approximately 20 years. She also assists Corrine Brown and Jose Serrano and several other members. But you know, taking on a delegate is not an easy task, and I want you to help me thank Hannah with a round of applause. So we're going to take some pictures.
I want to thank you so much, Congresswoman. I've enjoyed every minute of it.
Thank you. And from the staff, from our staff, Hannah, we have a little present for you. We wanted to bring a little bit of Virgin Islands to you. So these are some Virgin Islands made products. One is a batik scarf that's made there, and the other one is a mahogany bowl. So. Wow. Okay. So thank you. Let's give all of the awardees another round of applause, and we're moving into the next. And we'll get ready for our next panel, Saving Our African American Providers. So if you want to take a little break as we move our next panel up to the stage, you got about 5 minutes. Oh, actually, you could take a 15-minute break. I think, yeah, we're right on schedule, so I'd say 15 minutes, be back at 2:20 we'll start.